Hello, I'm Suresh Gunasekaran, CEO of University of Iowa Hospitals and Clinics and Associate Vice President for UI Healthcare. We are delighted to again be part of the Iowa Ideas Conference. Now in its fourth year, Iowa Ideas provides a unique opportunity to bring together a wide variety of different voices, perspectives, and thoughts to create a better future for us all. 2020 is a year that none of us could have predicted and has given us unprecedented healthcare challenges. In some ways, these challenges have made us better at delivering care, but it has also further highlighted the serious gaps some Iowans face in receiving adequate healthcare services. Let's start the discussions here and follow through to deliver better health for all. Thank you for being a part of this important discussion.
Thank you very much. My name is Craig Gemoules. I'm the managing editor of the Gazette newspaper. We are very lucky that we have with us three very expert panelists to talk about rural healthcare issues, which is a matter that I think is very near and dear to a lot of our hearts, being in Iowa. And to help navigate us through this conversation, we have Allan Morgan, who's the Chief Executive Officer of the National Rural Health Association. And he is one of the leading voices in the country on rural healthcare policy. We also have Debra Hoyle, who is president of the Iowa Rural Health Association. She works currently at the University of Iowa Carver College of Medicine. In a past life, she helped set up the system for recruiting and retaining dentists in Iowa. And we also have Keith Mueller, who is director of the Rural Policy Research Institute and is head of the department at the University of Iowa of Health Management and Policy in the College of Public Health. So we have a lot to unpack here. Rural healthcare is one of the biggest issues I think we face in Iowa right now, or nationwide perhaps. And to kind of get us started, I want Allan to kind of set the table a little bit about what are the issues we face nationally and barriers we face nationally in rural healthcare. If you're in an area outside of an urban center, what kind of healthcare can you expect? And what experiences are people going to have trying to access the healthcare system from a rural area?
Great, thanks, Craig. Yeah, it makes sense that let's take a look at what we're seeing nationally for rural communities across the U.S., and then we can take a deep dive into what that means to rural communities there in Iowa. Nationally, rural is not a small version of urban. It really is a unique healthcare delivery environment. And by that I mean these communities all across the U.S., small towns, have a greater percentage of elderly, low income, and those in many cases with multiple chronic care issues. And unfortunately, this is the population that is most at risk for COVID-19. So what we're seeing in the pandemic now as it moves across the United States is a lot of the challenges and inequities that we faced in a rural health standpoint are just simply amplified by the pandemic we're seeing right now. And that includes challenges of workforce recruitment and retention. It challenges us on what services are actually available in a rural context. It's so important to note that these rural hospitals, they are designed for primary care and general surgery. They were never designed for global pandemic response. And it's putting these healthcare professionals and points of care at tremendous stress right now. We're seeing a national rural hospital closure crisis. Nationwide, we've seen 132 rural hospitals close over the last decade. 15 have closed just in this year alone. And so the challenge of us going ahead is, how do we maintain these points of access to care in the midst of a global pandemic that, as we're moving into the fall, really becomes a rural story? According to data developed by the Rural Policy Research Institute that you'll hear from Keith coming up, we've now had over 1 million rural positive cases in COVID, more than 20,000 deaths in rural America. But the challenge I think for us, and I hope we talk a little bit more about, is nationally the lack of specialty care in many of these rural hospitals. Telehealth and telehealth applications has the promise to bring specialists into these rural communities. But unfortunately, at a national level, we're really not talking about the long-term health consequences of suffering from COVID-19. We focus so much on the mortality, not on these long-term consequences that are going to result in multiple chronic care issues and needs for care going ahead. So I hope I've done a good job of articulating the challenges we've had. What's that now in relation to COVID? And also, since I highlighted telehealth, I hope we get into talking about some of the few good aspects that we've seen as a result of this pandemic, which has really forced innovation and new ways of thinking at a rural level. So Craig, how's that for a setup?
Thank you very much. Just to kind of encapsulate a little bit. So we're talking about what's at stake here is the future of hospitals, rural hospitals, whether or not somebody who needs health care who lives in a rural area would be able to access it without driving a horribly long distance. When you talk about telehealth in particular, what it might cost out of pocket. Keith, let me talk a little bit, drill down a little bit into Iowa, because Iowa obviously is facing the same issues. But I wonder if Iowa has a little bit of a different take on it with the aging population in Iowa. That's true nationally, but it's really true in Iowa. And the farming occupation is much more dangerous, I think, than most people realize. I don't know if that adds another layer of complication to the needs that people might have being injured on the job out in the middle of a farm field somewhere or in a grain bin. Is there something, when you look at this national landscape and you zero in on Iowa, is there anything particular about Iowa that stands out that is a barrier or an obstacle that we have to overcome?
Actually, I'm going to characterize it almost as an opportunity, Craig, and not a barrier or obstacle, but a way for us to think about this. And I'm playing off of an article that appeared in your newspaper this morning. It was covering the election, but it talked about the economic hubs in Iowa, and in particular, because it was covering the congressional district you're sitting in, talked about Waterloo in Cedar Falls, Cedar Rapids, Dubuque, as hubs in economic activity related to the small towns in the area. I think the same thing is true in healthcare, that when we're dealing with issues of access to specialty services, for example, that Allan brought up, we have opportunities in Iowa to deal with that in sort of regional concepts and think about people that could access the larger tertiary facilities in Cedar Rapids and have a relationship between those specialists and facilities and where they are in some of the outlying communities in that district. So that's something we can be looking at. I think we're being compelled to look at that. Now, when you talk about barriers for people to overcome, in the arena, for example, of delivery of new children and OBGYN services, we've seen over 40 of those close down in the small rural hospitals in Iowa over the last 10 years. So now we need to think about the connectivity between the women in those communities and a specialist somewhere else. Telehealth is one way to address that during their pregnancy. And then as they approach delivery, how do we make those connections? And I do think we need to be looking also at, and I'll close with a quick comment on the financing side, the consequences here in the last year now of people having difficulty with health insurance and understanding what they can do if they're furloughed or laid off of their employer. Admittedly, Iowa is in better shape economically than a lot of states, but we're still confronting that issue during the pandemic of people losing employer-based insurance, and then what are the options for them to undertake. And that has a reverberating effect back on the delivery system because it changes the ability to collect payment, frankly, when you've delivered the service in some of the small rural hospitals. So I'll pause there.
Well, thank you. For those who are joining us just now, I want to remind everybody this is the Rural Healthcare Issues panel. We're talking about issues about rural healthcare in Iowa in particular, and overcoming challenges, meeting the challenges. If you stumbled upon our room by mistake, meant to go to a different track, you're welcome to stay here. As I've said in a previous session, this is not like getting on the wrong plane at the airport. Your luggage is not going to go to Hawaii and you to Peoria. You're welcome to stay with us and come along for the ride. So hopefully if you stumbled upon us by mistake, you're more than welcome to stay. Debra, I was going to talk a little bit. I'm not sure if this is, Keith may want to weigh in on this as well, but when we talk about rural healthcare and improving rural healthcare, I think that people generally think about family medicine, talk about medical doctors. But the needs in Iowa extend beyond what people might think of as a primary care physician. It's mental health, it's dentists, it's pharmacies. Can you talk about that a little bit about in terms of just what the needs are?
Sure. So oftentimes, like you said and mentioned, primary care is the main focus in medicine and healthcare that people are looking at. But as you mentioned before, I spent time working within dentistry, and certainly I found that over half of the dentists in our state were over the age of 50. And so when you start looking forward towards retirements, that is going to have an impact on the state, and more specifically on the people who live in our communities, if we don't do something to continue to let graduating students know that the opportunities exist. That's just one example, is dentistry, but we have home health care, community providers that are out there that, they're going into the homes and they're providing an invaluable service to people so that they can receive the care in their home rather than having to be in a hospital or a nursing home or some other type of rehabilitative facility. So that's another thing that potentially is getting overlooked for needs assessments out there. Pharmacists, historically, there have been a lot of our pharmacies that have been independently owned, that have now closed in these rural communities. And depending on the size of the community, there may or may not be a retailer pharmacy that's come in to replace it. The list goes on and on, to be quite honest. Optometrists, that is something that I used to get a lot of questions about, how do we get an optometrist, because we need an optometrist out there in the community. Chiropractors, physical therapists. Where do you want me to stop?
No, you could definitely write a book about this, and people that have written books about this.
Did.
Dan, on the personal level here, I know everybody has a story to tell about rural healthcare, probably, and in my case, it's near and dear to my heart because I have a 92-year-old father who's soon to be 93, and he lives 2 hours outside of Iowa City. And yet his doctors are all based in Iowa City. And it's like, well, drive to Iowa City to get your care. which is an incredibly hard obstacle for somebody who's 93 years old almost, and has macular degeneration. I know that we made great strides with telehealth. That is, especially during the COVID era, that has really been a bigger thing than it had been already. But there are limitations to that, obviously, in trying to reach people who live in rural areas, who can't drive to city centers to get care. There's been some pluses and minuses with that. I just wonder if you could talk to us a little bit about kind of your take on telehealth and what still needs to happen to make that a success in terms of financially, in terms of access, and of course there has to be not only a patient on one end, but there has to be a doctor on the other end of it also. So I just wonder if you could kind of walk us through what you think needs to happen with to continue the growth of telehealth as a possible solution.
So, telehealth is one of the things that kind of has flourished during COVID. It's one of the positives, if we're looking for some.
Yeah.
One of the things with that is payment parity. Currently, there is a mandate that insurance is to pay the same level that they would pay for an inpatient visit. After the time expires on that, the insurance could go back to paying less. And the reality is there are costs associated with doing that telehealth visit that don't actually change whether it's in an inpatient or a telehealth visit. The cost for the provider remains the same. There's the technology that needs to be covered, and so on. So certainly that is an incredibly large factor in that. Another piece of it is the expansion of rural broadband. Connectivity is an incredibly key element in being able to have appointments happen that way. And so certainly we need to be looking at how do we get it expanded out there. And I know it's been a large topic of conversation through the years. I've participated in those conversations. But if we have that, we will only be able to expand that as a service. The other part of it is that we need to have, so in the realm of mental health for counseling, we need to have that an audio appointment will receive parity with a telehealth appointment. It's the same service, you just can't see each other. And certainly telehealth would allow for a specialist who is not located in the rural community to be able to collaborate with the provider who is there to extend the care that the patient actually needs and get that access to them.
The Keith or Debra, either one, on telehealth. I don't want to spend the entire time on telehealth, but on that topic, the payment parity, the way I understand it, is that it used to be that insurance companies would reimburse only part of the cost. You had you're out of a fairly high out-of-pocket expense you had to cover, and during the COVID era, the requirement is that gets reimbursed at 100%, or it gets covered at the full extent that would cover an in-person visit. Now, does that expire at the end of whenever this emergency order expires, or is there some other legislation that's pending that people should keep an eye on?
The answer is actually yes and yes. Yes, the current provisions will expire at the end of the public health emergency, whether they are federal provisions tied to that emergency, which currently runs through January 21st, I believe, of 2021, or there are state provisions that would be the ones governing insurance plans that run the life of the state public health emergency. Uh, the answer is also yes, there is legislation pending, both state and federal, that would either extend those deadlines or make some of those changes permanent. There are some sort of balancing considerations, if you will, with telehealth. Excuse me. One of those is it truly a cost-effective delivery modality, if you will, for the providers involved and the consumers, the patients? We've been monitoring studies of the utilization of telehealth during the pandemic, and it's been fascinating. There was a major increase in the first 6-8 weeks of some of the new ways you could use telehealth, and then a decrease after that increase. It's still at a level above where it was pre-public health emergency. I mentioned that trend because one of the elements here is, will enough people, and this is where the cost effectiveness to the provider enters in, would enough of the patient population use telehealth to make it a cost-effective way of delivering the care? So that's why we should monitor patient utilization now. I don't have a firm answer to that. It looks to me like it's probably yes, but that sort of trend line is something to watch. And the other piece of the cost element that's always been a concern of the insurance plans, whether they're public or private, is if you open up new channels to access care, will you have an unnecessary spike and overutilization of the services, and therefore a lot of expenditure for people that are using telehealth that previously would have just taken care of whatever the emerging condition is on their own? And I think those are legitimate questions. We should be trying to answer those now that we're using telehealth and have the data collection going on. And I know there are investigators around the country, some here in our own college, who are looking at that. I think there are answers to those questions so that we can get to a point where these policies can be permanent and both the payer and the consumer can be confident in using the services.
One of the things that the governor will address when she speaks at 12:30, it's a recorded interview, we're playing at 12:30. She is going to talk about broadband a little bit, about efforts to expand broadband, and that's a key to so many different things, including telehealth, but it impacts everything, more or less, from precision agriculture to distance learning, and of course, telehealth. But speaking of the governor, every January she stands before the legislature, the opening day of the legislative session, and gives a condition of the state and implores she lays out her agenda, and she encourages the legislature to go along with it. Keith, if you could stand up there and you were the governor for a day and you were employing the legislature to pass certain policies, particularly when it comes to rural health care, are there 3 to 5 things you would say, these are the things that the Iowa legislature could do to help rural health care the most? Kind of putting you on the spot with that question, but
yes, you are. I think foremost in those would be to continue to work on what Debra was referring to earlier, and I'll put it under a bucket called workforce issues, and support innovative programs that address that, and do that through private-public partnerships. This is something we worked on out of our Center for the Department of Public Health 2 or 3 years ago. And we convened a group of people that included representatives from some of our big health systems in the state. They have the same concerns about, do we have the right mix in number of professionals where we need them? Are we supporting them appropriately with telehealth services, provider to provider telehealth, something we haven't talked about? That's important. And I think those kinds of conversations can produce ideas that say this is where an appropriate infusion of public effort, some of which is not financial, some of which may involve looking at scope of practice and what the various levels of professionals can do. So we're optimizing everybody's full trained capacity. Others might be, and Iowa has been, I think, a leader in this, paying attention to issues around caregivers, whether they are formal healthcare professionals or informal caregivers. The situation you mentioned of someone transporting your father at age 93, well, community-based health workers who are not healthcare professionals per se could help with communication in telehealth to him where he lives. They could also help develop a transportation service that would transport when needed into the community. And the public role here is one of convening and promoting some of these options. It's not terribly expensive, but if there's not a sort of a coordinating function going on, it's very difficult to build and sustain that kind of community-based activity.
You mentioned workforce, which is interesting because so many of these different elements are it's like a giant game of dominoes, are all interconnected. Whatever happens over here may affect something over here. And you mentioned workforce, which has been an issue in Iowa for a long time, which is how do we attract people to the state and retain talented people in the state. And Debra, I know you've talked before about getting a lot of people around the table. That if you look at rural healthcare, improving rural healthcare with adding people, that it's not just a zero-sum game. That it involves a whole bunch of different things that might come under the category of quality of life. And I know you've talked about getting a wide variety of people around the table to solve these issues. Do you want to talk about that a little bit, some more about kind of how you see all this, who should be around the table, and what other things should we talk about that go hand in glove with improving healthcare?
Sure. So this is something that I used to do very frequently. And it's something that I very much learned as I was building the program, that no two communities are going to have exactly the same players at the table. But what I do know is that everything in a community in our state, it operates, it no longer operates in silos. And COVID has been has created the perfect example of how we have something happening in health, and the next thing you know, it's actually affecting our economy, it's affecting our education, and all of that. And so the infrastructure of a community is more than one thing, it's everything. So when you're looking at who should be at the table, that's what you need to look at in your community, is what are the essential components of our infrastructure, and then you invite them to the table. Always, you should have someone from economic development at the table, whether it's somebody that's through the chamber, if it's an actual, the community's economic development group, the counties, what have you. It's good to have someone at the table who represents education. People coming into the community who have children are always interested in what is available education-wise in the community, and how does that lay out there. You always want the person who's incredibly passionate about the community. They may not have a position that you would ordinarily think plays into the recruitment and retention, but the person who loves that community and can express why they love that community, absolutely is somebody who should be at the table. But also thinking more out of the box. Arts and culture is a big thing to people. It's not always something that is looked at as a necessary entity in a community, and yet It is. Through our arts, culture, activities, entertainment, what have you, that happens in a community, whether it's the local pool or it's a theater, restaurants, that's all a part of a community, and it's all part of what plays into our socialization within the community, but it also affects our mental health. So while it may not be considered the first priority when it comes to financing a project in the community, think outside the box about the things that you could do. If you have a venue that's, not being used, could it be turned into a live music venue, or where plays could be put on, and you create a community theater that could be done, relatively inexpensive, that ultimately will bring value to the community. And then in turn, it will actually help to attract people to that community as well.
Speaking of thinking out of the box, Allan, one thing that we've been talking about brain drain in Iowa and probably elsewhere for years, that people come here, they go to get training in our University of Iowa, and then as soon as they graduate, they leave. And we've had trouble retaining or attracting people, healthcare professionals or otherwise, to the state. And when we do attract them, we're surprised by the fact that they leave after a couple of years. I know you've done some looking into this in the past about kind of what might work better if we take somebody from Manhattan and the next thing they're working in law school is Iowa, and we're surprised that they don't stay. Can you talk about that for a little bit, about what our expectations have been in the past and maybe how that's changing? Are there any kind of success stories out there or things we should look at where we might have more success at recruiting, retaining people than we have been?
Such a great question. Thanks, Craig. Yeah, I think I want to say almost, but actually in every conversation that I have about rural America and rural health, it always goes the same way. And that is, we spend about an hour talking about what we don't have. We talk about the shortages, the obstacles, the challenges, and we completely forget the simple fact that all innovation when it comes to healthcare and healthcare policy has its origins in a rural context. And that's because in these small towns, you have small organizations, and it's very easy to innovate, see what works, adopt it, or change the path, whether it's community health workers, patient navigators, dental health aides, the concept of team-based approach healthcare, all had their origins in rural. We started off talking about telehealth, and telehealth is about rural America. Well, except for space, but let's be honest, what's more rural than space? Yeah. So it is where all these innovations begin. And then we spend a lot of time talking about, well, we just can't keep people there in rural, they move away. But the truth of the matter is, certainly for healthcare, as a nation, we take the kids that score the highest on the MCAT test. They're really bright kids from urban areas, upper income urban areas, and then we train them in an urban setting across the US. And then, like you mentioned, we're just dumbfounded that they don't want to practice in rural, underserved America when there are literally millions of rural residents that would love nothing more than to find a good profession that allows them to be able to live and work where they want to be. And say, to your point, there over the last many years, actually, but most particularly the last decade, there's been this concept of rural residency training programs, and actually attracting kids from these small towns that are doing fantastic academically, put them into programs with their peers, train them in a rural setting, and then place them in a rural setting, and lo and behold, they stay. We just do this completely backwards, and then we're dumbfounded that we get the results that we have. I think a lot of it just has, how do we shift this discussion of thinking of rural Iowa as being some backwater area that all these kids are trying to escape from, when in fact, people would love to be in a place where you can camp, hike, fish, your community, they know you have a sense of community. There's so many assets for rural Iowa that we should be talking about. in addition to recognizing some of the challenges and obstacles that we face.
You know, Iowa has currently a social media program running in Manhattan where they talk about they pose as a realtor, and they can offer a 3-bedroom house within walking distance of restaurants and craft breweries for $250,000, but it's in Waterloo, Iowa. And I don't know how successful that would be in attracting anybody, but that's kind of the point, is that there probably is a higher quality of life than maybe people realize once they're here. What has gone hand in glove with attracting and retaining people here has been financial incentives. And we've done all kinds of different things on the legislative side where there's been an attempt to have more Iowa people be in the College of Medicine, or different incentives talked about, sometimes passing and not passing. How important is it to have programs where people are lured here to stay here with financial incentives? Does that work, or is it the kind of thing where somebody stays for 5 years and then leaves? Or how important are financial incentives for your standpoint? This really is a question that could be open to anybody.
Yeah.
In terms of being able to attract people and to retain people with a financial incentive.
Yeah, it's a great question. I know Debra and Keith both can talk to this as well, but let me just say, yes, it's incredibly successful with the right candidate. Where we've seen the most success is when at the community level, when kids are in high school, in many cases, there are actual local financial assistance to make sure that kids can come back to their community. That's number one. There actually is the National Health Service Corps program at the federal level. If you agree to serve in an underserved area, which just happens to almost always be rural areas, they will be able to forgive your debts. There are state-based programs as well. But to your point, it does no good whatsoever if you're getting an upper income kid from LA and forgiving their debts if they agree to save for 5 years in Iowa in a small town. They're going to stay for 5 years and they leave, and everyone says, well, that's a shame. That program obviously doesn't work. No, we need to stop doing how we've been doing. They really needed to be targeted towards Iowa kids. It makes no sense how we're doing this. And I understand that a lot of the academic institutions don't share the thought on this, and the counter to this is, well, you have to look, and the vast majority of these kids are from urban areas. You can't shut them out. Yes, their vast majority are from urban areas because we're doing it wrong. We really need to rethink this. And I'll turn it over to others to talk about there at a local level.
Yeah, I'm interested in that. Keith, do you want to follow up on that a little bit?
Well, as you were phrasing the question, Craig, and listening to Allan's answer, what was running through my mind is, at a minimum, we don't want the financial circumstances to drive people away. We want to facilitate their choice. And so we know, and this comes again out of our work when we're talking with private employers, we know that for especially the professions of greatest shortage, that somebody in the private sector is going to offer them loan repayment and offer them high salaries, if not loan repayment, sometimes both. We have to level that playing field so we don't lose the kinds of students that Allan was describing from rural, because they just can't. They look at, if I went to place A, I'd get my entire loan repaid and a pretty good startup salary. If I go to the rural community, I get a partial loan repayment and a lower startup salary. It makes that decision a financial one, and we don't want that to be a financial decision. We want it to be a location decision. So my view of looking at those kinds of loan repayment policies, et cetera, is exactly that. Leveling the playing field so the decision is based on location. Combine that with the kind of program that Allan talked about, where we're generating more students for whom that decision location would be rural. Now we can bring them to rural and they will stay. So,
What are some of the success stories you guys are seeing in Iowa where we're chipping away at improving rural health, besides telehealth? But I think that's a given that's been a kind of silver lining to at least for now, in the COVID era. What other programs are you guys seeing that has some glimmer of hope that seem to be working the way we should, and we should replicate those?
I was looking to Debra to start our answer on that.
Of course. So with respect to, dentistry is one thing that I'm always fairly fluent in because I spent so much time doing it. During my time, definitely I was seeing inroads. There came a point where, I don't know how many people are actually aware in our state that at the university, we have a program that tracks a number of our healthcare professions in our state. So we know how many dentists we have, we know where they are. Same goes for physicians, pharmacists, and nurses. And so with that, I would work with the community. I would work with Iowa Area Development Group. Iowa Area Development Group is still working with dental students to help them to identify and then locate in a rural community. And in working with the community, then they look at, potentially tax abatement for if they're going to be starting their own practice. Is there something that can be done for housing, and so on and so forth? And there's a program through USDA Rural Development that can come through as a low interest loan when it comes to the practice side of things. But so there was also the ability to apply for loan repayment. It wasn't just that they would receive the money with nothing in return. In return, they would agree to see 35% underserved. And the model was working. A number of the people, or the vast majority of the people who would receive the loan repayment and were in our rural communities, even after their obligation ended, they stayed. And part of that piece was also, I sat down with them, and because of the background that I have, I was able to actually work with them to help them really identify what it was that they really wanted for their life immediately and down the road, and help them to identify how that picture could look for them and some of the steps to get there. And that's, I feel that is also a really important piece to it. And sometimes I was just the cheerleader saying, I believe in you and I know you can do this. So there's that. When it comes to medicine, certainly we have 2 med schools in the state, but we only have one of our institutions that has the residency programs, and then also works with affiliated residency programs throughout the state. And so I know that, opportunities are collected there, and then they are shared with residents so that they are aware of what opportunities are available here in the state. And there can be assistance with helping them look at contracts, but also in connecting them with, whoever the recruiter might be at a hospital, or the CEO, and helping them facilitate a connection that way. With pharmacists, I know the Pharmacy Association in the state works with the pharmacy schools to help their students identify what opportunities are available when they're getting done.
So I wanted to get to the question of kind of what's at stake if we don't improve rural healthcare. And we have, questions of access in terms of whether telehealth, whether I actually have the broadband that can access this, and and access in terms of like physical distance, how far do I have to drive to see a doctor or have a baby. And obviously there are financial obstacles as well in terms of how much do I pay out of pocket versus how well I'm insured. But talk to us, and maybe this is a question to start with Allan. Kind of what is at stake here if we don't move the needle on rural healthcare and addressing these issues more than we have been?
Oh, yeah, that's a great question, Craig. Thanks for teeing that one up. Yeah, I think for a long time, when you talk with policy leaders at the federal level and certainly at the state level, you talk about rural communities, and the response is usually, what are you going to do? Everyone's getting old, they're dying, they're moving away. What are you going to do? But according to the Census Department, that is no longer the case. Over the last 5 years, we've actually seen a leveling off of rural populations. Rural adjacent to urban have actually seen fairly dramatic increases. So this thought that rural America is dying away just doesn't bear out. And this pandemic has dramatically changed how we're going to talk about it going forward. Everyone on the call knows, I mean, people are trying as quickly as they can to get to leave the urban hubs and get out where they want to be, because now you can do work on your laptop anywhere. And when people are allowed to live where they want because of technology, they're choosing rural areas. Directly to your question, we have this population shift and an increase in population. Right now, there are rural communities that have 20 years fewer life expectancy in a rural area than they would have on an urban area. So this is so very important that we have this healthcare position to make sure that we keep rural communities healthy and safe, and we're able to have a sustainable rural America as we move forward.
You know, speaking of rural and COVID, at least in Iowa, some of the highest 14-day rolling averages of positivity are in rural areas, to say the least. And the number of cases might be lower, but the positivity rate of the people being tested are much higher. So that raises another level of rural healthcare going on right now. And like you say, you know, if you're in a rural area and you are symptomatic, think about how disruptive that is if you have to go to a hospital in Cedar Rapids or Iowa City or Des Moines or Sioux City. Your whole, you know, it uproots your entire family, perhaps. As we move forward on all these different programs and ideas that are out there, what are some of the things, and this is probably anybody can answer this question, I'd be interested in kind of getting everybody's take on it. What are the things that the public should look at to see if we're making progress? Is it the number of healthcare professionals we attract to rural areas? Is it the number of hospitals that close? Is it aid that Congress provides? Maybe it's all. But are there some signs that the public should look at to gauge for themselves whether we're making progress on improving rural healthcare or not?
Yeah, let me take a first crack at this if I could. In some regards, it is all the above. You just can't live in a community safely where you don't have access to 24/7 emergency room services within 30 minutes. So if you don't have that, seniors are going to be moving away from your small town. If you don't have services to maternity care and OB services, you're not going to have young families moving into your town. So from an access standpoint, you have to have those two. People need to realize that these rural, and we talk a lot about rural hospitals, for the majority of rural counties are the largest employer, with the exception of a swath of the Midwest and Western Kansas, Western South and North Dakota, and Nebraska. Healthcare is the largest employer. They are the anchor institution of these rural communities. So you need to make sure that you maintain those points to maintain a future. But to your point, at the end of the day, it's about the communities. What is happening with chronic care issues, life expectancy, cancer rates, COPD. Look at the metrics that are being tracked about the health as well as the health care of these rural communities.
Yeah, I agree with everything that Allan is saying. And when I try to think through, Craig, your question of, if I look around me as just a member of the community, what do I see? What's the evidence, direct evidence of something happening? And I think that emergency services, for example, needs a physical presence in the community. In places where hospitals have closed, and we've been fortunate in Iowa, we're not hit by the hospital closure issue as hard as in many of our neighboring states. But even here, we need to be focused on that presence of emergency services. Is there a place in the community where I can go and have access to the first level of care that is then coordinated, even if the other levels of care, beyond the primary care, are not in the community, but is coordinated? I need to see that physically. I need to see the emergency services. I need to see there's a place that I have access into the healthcare delivery system. I need to see there's a place I can get my pharmaceutical services taken care of. And then I would add, I need to see a place where if I need rehab care, or if I'm in the elderly cohort, which I am, there would be a place, heaven forbid, that I need skilled nursing, that I can get that in the community. Those are things I need to visibly see. Then if I have the effort, if I have the energy to dig beyond that, going to Allan's point, I would be looking at some of those health indicators. I'd be looking at, am I connected in the community to services outside the community? So I would look immediately in my own home environment. Do I have the high-speed connection I need fully? And if I don't, do I have an easy way to get at that? So I can make an initial phone contact, and then there's a point of access where I can get the high-speed access. So there's sort of levels of how I would view it.
I think a lot of us have looked at, not so much in Iowa, but around the country, we've seen hospitals close. Somebody talked earlier about we fixated so much on the things that we don't have rather than the things we do have. And it's kind of the same way when the public gauges the healthcare of its community. I think it's easy to look at the things we don't have versus the things we do have. On that point, is there anything the members of the public can do to advocate for better rural health care? Is that, it could be as simple as writing to a legislator. It could be welcoming the new resident in town who's going through a training program. Is there anything that the public should be doing that would improve rural health care? I don't know if there is, but is there anything that members of the public who may be watching us now could actually go out and do?
Oh, absolutely.
Yeah.
And I know this is something that all three of us panelists would have something to contribute on this. But one, recognizing the value of the healthcare there in your community and utilizing that healthcare. I mean, the data just shows when you're talking about primary care and general surgery, you can trust your local healthcare. It is a great place. You need to utilize your local healthcare so that way it stays in your local community, number one. Number two, being an advocate for your community. At the federal level, we can talk all we want about rural in totality, but policymakers want to hear about the impact at the local level. What does it mean to you, your family, your loved ones, and your friends? There's a lot of really arcane discussions about Medicare reimbursement and workforce policies. What does it mean there at your local level? If you can just share that and be a trusted resource to policymakers where they know they can turn to you because you can share the story of what it means there in your community. I cannot stress that enough, the value and the impact that is. And I'll turn it over to the others.
So I was actually just having a conversation with one of our board members a couple of weeks ago. And we were talking about, the umbrella of healthcare covers so much. And, one of the things that came up in the conversation was food deserts. But that's something you can look at how you can address that in your community. If you don't have a grocery store, maybe there's something that you can create as a food pantry in your community that can help to provide food, but not only that, farm to table type of options. Also wellness. There's been, different communities that have done their fundraisers to start something that addresses wellness, whether it's trying to get a trail put into their community, or one community, they actually opened their own fitness center in town, and it's had a high success rate and is well used. So looking at some of those things, unfortunately, you have to have the conversation about what you don't actually have, but then
Right.
look at what can you actually do from there. And so be engaged and be part of those conversations, but even more importantly, then be part of the action plan to bring it to life and fruition.
Thank you.
I would
Keith,
just add,
yeah, I don't know if you want to weigh in on this or not. Yeah, go ahead.
I was going to add, sort of playing off of both of these comments, but Allan's in particular, be sure that the people who are providing a lot of these services are recognized and thanked. I mean, running through my mind is the yard signs I see around Iowa City and Coralville, where I am, thanking the healthcare professionals during the time that we're going through now. I'm thinking, well, we should be thanking them a little bit more often, and in particular in the small rural communities.
That's true. Thank you very much. We are almost out of time here. How time flies. We could write an entire book about this and a movie and still go at it. But I want to thank you guys for your time and sharing your expertise with us. People who are watching this can continue to try to get in touch with you afterwards if they have questions they want to follow up on. Everybody's bio and contact information is on the Who've site that people are watching this through. I wanted to thank everybody for your time. This was a great panel. I'm glad you could carve out the time to meet with us today. We have lunch next, so a little bit of a break. And then the governor will speak and do a question and answer session with our executive editor at 12:30. So people may want to watch that as well. Thank you very much for your time, and I'll see you guys later.
Okay, thank you.
Bye.
Thank you.